let me introduce the first speaker for today's program. And on behalf of CAHO and ASQA, I welcome all of you for this fantastic feast of deliberations on enhanced communication. So with this introduction, let me introduce Dr. Karen Luxford. Dr. Karen Luxford is the Chief Executive Officer of Australian Council on Healthcare Standards in Australia, and she has a vast experience in communication, the effective communication and enhanced communications. And she's going to share with us the experience, the Australian experience in communication errors. Madam, over to you.
Thank you very much, Dr. Suneel. It's a pleasure to have been invited to be a part of this event today. I'm speaking to you from Sydney in Australia, but wonderful to be able to share some of these learnings with you. I wanted to say a special thank you to CAHO and to ASQA for the invitation and for inviting me to talk. I've shared my screen. I hope you can see my slides now. And I was invited to speak on this very important topic of communication in healthcare. And this has been something that I've been very focused on over many years, as it is a really critical part of patient safety and quality improvement. So I'm going to share with you some of those learnings from the Australian experience. I wanted just to give you a little overview of what I'm planning to talk on. Firstly, some of that experience from Australia and some international evidence. The important issue of identifying harm and causes, and then improving communication for safety, engagement with patients and families, which is critical in this area, and then I'm going to finish with a case study. So for those of you who don't know ACHS, the Australian Council on Healthcare Standards, we are Australia's largest and longest established quality improvement agency. We accredit over 1,600 organisations in Australia, and through ACHS International, we're in 15 different countries around the world. We have within our organisation representation from all the clinical colleges in Australia, the consumer groups, from government, from a whole range of different groups in our governance, and helping to advise our board so that we know the sorts of directions that we should be heading. ACHS in Australia is an independent non-government group and a non-for-profit, and our council through those representations informs the direction that we're taking. So I'm very excited to be the group CEO of both ACHS and ACHS International. So in Australia, we often don't beat our own drum. I don't know if that is a phrase that you use in India, but we tend to hide ourselves under a bushel. But I was very excited in the last year to see some of this data coming out from the philanthropic group, the Commonwealth Fund, which ranks the Australian healthcare system in the top 3 internationally. In terms of overall performance, and we rated #1 for health outcomes and for equity in health. And so we were very, very excited to see that. And typically Australia and our healthcare system does rate over many years in the top 5 and more recently in the top 3. So I wanted just to start with a little bit of background around some of the work in communication that has happened in Australia. And we did some very seminal work in this area around adverse events. And this study from 1995 was one of the first studies in the world to actually look at exploring safety and quality improvement across the healthcare system. And it was the first big study around adverse events. It was published in our medical journal in Australia. And I'm pleased to say, if you can see the fine print down the bottom here with the various authors, that the head of the ACHS Improvement Academy, Bernie Harrison, just here in the middle, was an author on this very important piece of research. And what it showed was that 16% of patients in hospitals experience some form of adverse event during their admission, and 50% of these events were preventable. So this was an absolutely world-mark leading study that showed we really do need to do things differently in healthcare. And so coming off the back of that, there were standards developed at a national level, and a number of those standards focused on the importance of open disclosure when incidents occur, and making sure that incident management and investigation systems are put in place. The culture of being open was something that needed quite a bit of work in the early days in Australia. Everyone was worried that if they spoke out and talked about incidents, that there would be a blame culture. So it's taken some time to turn that sort of thinking around, and making sure we've got the right kinds of systems in place for patients and carers to inform us about their own experience. Informed consent, absolutely critical. Having a safety culture across the organisation and making sure that people's roles and responsibilities are clearly outlined in clinical governance. And when those standards were put in place, what we started to see over a number of years was a turnaround in the number of Sentinel events, and this is national data from Australia. And you can see at this point starting to have quite a steep drop-off in the number of Sentinel events that we saw from year to year. And similarly, we've seen the same sort of trend with the hospital-acquired complications. So these are separations per 10,000 separations over a number of years. And you can see that gradually the hospital-acquired complications have also been dropping. So when we're looking at incidents, we need to consider the multiple factors that actually contribute. And so over the years, there's been a move towards a systems level approach, also in the area of events and communication and its contribution. And so when we're looking now at incidents, we're focusing on a range of things: patient factors, provider factors, or human factors. And there's lots of work happening in the exciting area of human factors. Task factors, the tools and the techniques that we're using, the team and how the team actually works together. And I know you're having a presentation on team steps a little later, and environmental factors and the organisational factors themselves. So we know healthcare is complicated, and when we're trying to look at what contributes to incidents and events, that's complicated as well. So we really need to look at it in a multifactorial way. And with that complicated system, we are moving, as I said, towards a systemic approach where we look at the individual patient, the care team, and how the team interacts with each other, the organisation that delivers the care, and then the environment in which that care is delivered. Healthcare doesn't work in a bubble. It works in society and is influenced by a range of different factors. This was a study, I remember coming across this study a number of years ago, and I found it very enlightening because often in safety and quality, we have focused on the quality of the technical care, but the quality of the interpersonal relationships is just as important. And particularly those between the staff and the patients and the staff, and then the quality of the environment in which we deliver that care. So here's some work that we looked at a number of years ago in Australia, which tried to break down some of the causes of the sorts of events and incidents that we were seeing in healthcare. And what really stood out in this was that the majority of them, when you looked at the underlying causes, were linked to communication. And that was an area that we hadn't traditionally looked at. We'd spend a lot of time with standards, looking at policies and procedures. We'd looked at the patient factors. We'd thought about the things that were easier to control in terms of safety mechanisms and even the equipment. But we hadn't spent so much time thinking about the communication piece. And yet, when we look around the world, we see a whole range of incidents and some quite well-known cases of communication breakdowns, which have led, unfortunately, to patient harm and to the loss of life. And so it is important that we learn from these stories, we understand what is the basis of that breakdown in safety and quality. And really needing to reorientate the way that we deliver care to be person-centred. And what's exciting about that is it not only improves the patient's experience of care, but there is a lot of evidence about improvements in clinical and operational outcomes. And you can see a range of those listed there, including the satisfaction of the staff within their own workplace, and also on the finances of the organisation. So I was very honoured in Australia to have been the lead author on this book on patient-centred care. It was a national publication and focused on evidence as well as strategies that could be used to improve the way in which we delivered care. And communication was a key part of this publication. So strategies were disseminated across the country, integrated into standards. We have a big focus in ACHS on person-centred care, on making sure that communication is a central part of safety and of quality improvement. And I wanted just to share with you a case study that involved what we were noticing in Australia as really the rapid deterioration of patients in hospitals in particular, and trying to define where were the times in that trajectory of deterioration where we could intervene and make a difference. And again, there was a focus initially on clinical aspects because they were the things that we understood and the things that we thought we could do something about. This is some work involving the Clinical Excellence Commission in New South Wales, where I was a former executive director. And this is a slide from Charles Payne, one of my colleagues. And looking at this, what we call the slippery slope, we wanted to think about where were the points at which you could really intervene and make sure that patients didn't deteriorate and subsequently die. So from the clinical perspective, a program was developed which was called Between the Flags, which actually looked at patients' physical criteria and monitored those to try and keep them between the flags. In Australia, this is a surf life-saving analogy. We love the beach, we love to be in the ocean, and so it's always safest to swim between the flags. And so the program that was clinically focused looked at patients' vital signs and how you could keep them within that safe zone. But when I was thinking about this particular problem, I thought, again, there's a communication element here, and we went back through some of the incidents in the Australian situation, and what really occurred to me was that there were a number of cases which we would see happening again and again, where patients had actually raised the alarm quite early on, or they'd tried, and they'd also, patients' families and carers had tried to communicate and say something's just not right. And that was the language that we heard a lot. So we analysed a series of incidents and we found that phrase coming up again, something's just not right. And from the patient's perspective, the language wasn't clinical. They found it hard to put their finger on it, but they knew something really wasn't right and they were very concerned. So how were we listening to that patient voice and that communication and actually doing something about it? And so what I decided to do was to work with consumers, work with patients and families and carers on quality improvement. So this was a number of years ago. It was a bit radical at the time. There was a bit of pushback from some clinicians, and you know, often doctors saying, we don't know why we need to have the patients at the table. They're not necessarily the experts here. And so we worked carefully to find consumers who had experienced harm but wanted to give back in the system, wanted to be able to work together positively to ensure that harm didn't happen to others who were experiencing healthcare. And so I want to introduce you to Alicia. And this is a picture of Alicia. Alicia unfortunately lost her newborn baby in a hospital in Australia. And when she got a little bit further into her journey, she realised that she wanted to be able to give back to the system. She wanted to work together to improve care. And Alicia worked together with me and a group of consumers and clinicians all at the same table and policymakers to come up with a new system of what we call patient and family escalated rapid response. So normally it was the clinicians in the hospital who could call for a rapid response team, but we empowered the patients and the families to be able to call for a rapid response. And we knew that this wasn't going to be an easy thing to put in place. So we worked very collaboratively to make that happen. And so in this situation, we developed a system where patients, if they were really concerned about their state of well-being in the hospital, or if family were very concerned, that they could escalate through to the rapid response team, and that the team would be notified, would come to the bedside and would immediately assess that patient. And we talked to the patients about how not to use the system inappropriately, because if it was being used not in the correct way, then the doctors would lose faith in the system, but to actually use it appropriately when they were very concerned and they felt they might not have been being listened to by the care team at their immediate bedside. And we studied the whole process over a period of 12 months. We had a full research evaluation of it, and it was found to be effective. It was found not to be used inappropriately, and it was found to have saved lives. And that was all based on communication, just being able to listen to the patients and the families and the carers, and to be able to respond clinically and appropriately. So this is Alicia speaking at a conference about the outcomes of that study and the work that she inspired. So where we're at now in Australia is, I'm very pleased to say, that avoidable deaths and serious incidents have decreased significantly. And if you look at this data, again, from the Commonwealth Fund, you'll see a significant decrease, 18% decrease over a period of 10 years between 2009, when many of our strategies were put in place, and more recently to 2019, coming second only to Switzerland. So we're very pleased to see those improvements in Australian healthcare. So I wanted just to leave you with a mention of where we're heading now. In terms of our work with ACHS, we are developing new standards which have a continuing focus on patient-centered care and on the importance of working together and partnering. We've developed our new standards, Equip 7. They're going through the ISQA accreditation process at the moment, and we've included new modules within that set of standards. So if you'd like to learn more about where we're at ACHS, please do get in touch with us. It's been a great journey in Australia in terms of our focus on improving our communication. We continue to improve. There's still always things that need to be done in quality improvement. But I'm hoping that that has been of interest to you, and thank you again very much for inviting me to talk with you on this program.
That was a fantastic deliberation, madam. Sharing your experiences and engaging patients in decision making and working with consumers to improve communication and to reduce errors. That was a fantastic message at this era of atrocious behavior of the patients, resulting in problematic failure of communications in the healthcare setup in India. That was a very, very good experience from your side.